is Dr. Schroer.
Schroer, correct.
Okay, and he's with the Cleveland Clinic and the Center for Allergies.
Pediatric Allergy, right. So we're at the Cleveland Clinic Children's Hospital. I see patients downtown as well as on the east side. I'm at Solon and Twinsburg.
Well, thank you.
I see patients from all over. Well, I want to thank everybody for coming. I hope that the talk tonight is going to be kind of focused on you guys in terms of getting questions answered that you want. I wanted to have at least a handout, which I have at the front, if you haven't already picked it up, which has just generalities about food allergies. It can be a guide for what we talk about, but it doesn't have to be. So in that sense, I'm really here for you in the long run. Who here has kid with food allergies? Imagine it's pretty much everybody. Actually, I do too, if you didn't already know. My son has a milk allergy. He's 6.5, is our first kid. So I've experienced some of the stuff. Fortunately, it's just one. But I do know a little bit about it from a personal side. And I'll be willing to talk about that in generalities, as well as, if any questions come from you guys, feel free to ask. I'm going to answer in generalities as well. So don't worry about me telling you how to treat your kid on the podcast and having it come out on Pinterest or whatever. So when it comes to that, I figured I'd just at least start with what is a food allergy in general. Where do I come from when I listen to a story and hear about a kid who has a food allergy? What do I think about? And in that sense, I kind of break it down to immune reactions versus, say, intolerances. This isn't on the sheet necessarily, but that's just a common question I get. What's the difference between an allergy and an intolerance? It's hard in general to give a very perfect answer to it because there's so many possible things that foods can cause. But the way I really break it down is it an immune response to the food? Meaning, does your immune system recognize the proteins or other ingredients in the food and cause a reaction as a consequence of recognizing that food? Or an intolerance could be something like, caffeine makes you jittery if you drink too much of it. Or the more common, for adults at least, lactose intolerance, where the more volume you drink, the more sugar gets in your gut and the more you have bloating and diarrhea and gas. So in terms of that, I'm going to focus allergy as immune responses to food. But in general, most of the people who think about food allergy, they worry or have anaphylaxis. So that's the immediate reaction to the protein, where you eat the food and you have symptoms of itching in the mouth, sneezing, coughing either because of itching in the throat or swelling in the throat. More often it's coughing because of, say, asthma symptoms, even if the child doesn't have asthma. They'll often have stomach aches, and if they're old enough, they say, "Mom, my stomach hurts," but it's usually pretty obvious, even in young kids, that they go from happy to not so happy. Of course, vomiting is pretty objective. It's not a question when that happens. Then there may be hives on the face, or there may be hives on the rest of the body. And it's such a wide variety of reactions. Those are the overall symptoms, but it can be one or more of all of those things. So that's anaphylaxis. It usually occurs within minutes of eating the food. In a 1-year-old, it might be kind of scratching their mouth or rubbing. That's how my son presented. It could be sneezing, as a simple thing, and then sneezing, which of course happens all the time in ragweed season like it is now, but sneezing progressing to the coughing, the wheezing, the itching of the mouth, or the hives. So by far and away, the most common symptoms are itching, sneezing, hives, and the stomach ache and vomiting. It usually occurs within minutes, but it can occur up to 2 or 3 hours later. It's unusual at 4 hours. It's almost unheard of after that, in this area at the very least. So that's anaphylaxis in general. Other food allergy reactions can occur and cause specific problems in the esophagus, which is the tube connecting your mouth to your stomach, or the stomach in general. This would be something like eosinophilic esophagitis or eosinophilic stomach or intestinal diseases. Also, an allergy, a true allergy, would be something you might have heard about in kids like 2 or 3 or 4 months old, which is like the bloody stools from cow or milk, soy type of protein formulas, or maybe in breastfeeding infants, which is usually outgrown. But those are all immune responses to the food. So I wanted to at least get that out of the way. That's the first part of the handout I have. Some common misconceptions about what is allergy in that section I talked about hives, but there's a lot of kids, especially when they're 1 to 3 years old, when half the food gets in their mouth and half the food gets on their mouth, where they get hives around their mouth, but they eat it and nothing else happens. That's something called contact hives or contact urticaria. And it's not necessarily something you have to freak out about, especially if they did eat enough of the food that is like a whole serving, and that's all that happens. Actually, I would say you don't have to worry too much about that progressing. Actually, since I'm at that point, I have a thing on the back, just kind of like tips and miscellaneous kind of myths and stuff. I just thought about this right now, and I made this about 20 minutes before I left to come here. One thing that I hear a lot is from families and other doctors, ER doctors, pediatricians, is if it's bad one time, it will be worse the next time, which isn't true. Most often, it's the same. They eat the same food, they have the same reaction. Sometimes nothing happens. So sometimes it's better. It could be worse. So always, hope for the best, expect the worst in general. But my point with the contact hives is just because it happens once doesn't mean it will be worse the next time. But of course, if it keeps getting worse, you want to talk to somebody. So that's a common misconception I'd like to get out of the way. The other thing is something that's very common in kids who have anaphylaxis is kids have eczema. Whose kids have eczema? I won't say names. Yeah, almost all of us. So in that sense, one of the things I talk to people about when they come and talk to me about eczema is to say, what do you think causes eczema? And either because of Pinterest or because their doctor said it, they think the foods are causing the eczema, which isn't really true. It's the other way around. The eczema is what predisposes kids to become allergic to foods through mechanisms we fully don't understand, so let's stay off that topic because I don't think it'll be too useful. But kids with eczema are at risk for food allergies. But in general, kids with eczema aren't destined to have food allergies, and avoiding foods just isn't going to make the eczema get better because it's not what causes eczema alone. Foods may contribute to eczema to some degree, but it's one of many things. Bacteria on the skin, viruses, parasites, foods, in one case, dogs, cats, fragrances and detergents, soaps that are non-gentle soaps. There's all these different things that contribute to eczema. So I wanted to at least get that on the table, so it kind of helped guide where I'm coming from if you ask questions in general. That being said, what questions do you guys have about what a food allergy is? To stop here and just take a moment to reflect on what I said. I was expecting another question. Well, yeah. So plenty of kids can outgrow allergies, specifically to certain foods like milk and egg. It's much more common. But I think more and more with peanuts, we're recognizing that probably kids can outgrow it more often if you're aggressive at monitoring it. But it is much less common than, say, milk and egg. Tree nuts and peanuts are the kind of ones that are less common that you outgrow it. Soy, pretty common, outgrown. Other ones like fruits or vegetables, mostly outgrown. Sometimes they develop later, though.
Thanks.
What other question? So I think I forgot. The question is, if you go back and the kid is older and the tests are larger in terms of skin prick test size or blood test number goes up, does it necessarily mean that they're less likely to outgrow it?
Yes.
Of course, the answer in medicine always depends, right? So the scale for all those tests changes as the kid gets older. So a 2 at the age of 2 is, probably equivalent to a 4 at the age of 3. If you think about that sliding scale in high school math where the curve shifts to the right, I'm trying not to freak out about my high school math teacher again, but that's essentially what happens. Another thing I think I probably should have written down is getting to the tests. The tests themselves are only tests of how likely are you to be allergic, either if you're diagnosing it or monitoring it to see if you're outgrowing it. What the tests don't tell you is what kind of reaction will happen. So if you have a very mild peanut, like I'm going to say a scale from 0.35 to 100, and your number is 0.5, so very low, you can still have a very severe reaction. You can have another kid whose number is 50, and all they get is a little itchiness inside of their mouth. So it can be hard for us to figure out what's going to happen. So what I tell patients is, you tell me what's going to happen more based on what's already happened, either because of what's happened in the past, or maybe we do a challenge and unfortunately, I guess if you fail, then we find out what happened. So that's the situation with the tests. That gets a little bit to my second point, but was there other questions before we go on? So the second thing on the handout is, how do you know if you have a food allergy? And so that gets back to the testing. So, we know if you have a food allergy if you have a reaction when you eat it. That's the ultimate test. I know there's a lot of people maybe in this room, maybe not, who have had tests maybe before a kid's eaten it, but that's not the end test. Just because the test is positive doesn't mean you're allergic. So the first point I wrote there is that if a test is negative, so then you say, well, why even do the test? Like, what is it worth? They are worthwhile. They have value if they're negative. So if a skin test or blood test is negative, they are, in general, have a very low rate of false negatives. That's a negative test when the kid eats it and something actually happens. But is it possible that a negative test still leads to a reaction? Yes, that's possible, right? There's no perfect test besides eating it and seeing what happens. But what I was getting to before is that these tests come with a high rate of false positives. So that would be a test that's positive when they eat the food and nothing happens. So let's say I grabbed 100 2-year-olds out of daycare and tested them all for peanut. Probably 15% would be positive to peanut. But in general, only 2% of kids in America at least have peanut allergies in terms of anaphylaxis. So that's a lot of false positives. And it's worse in kids with eczema. So it makes it even harder to interpret. So the ultimate test is eat it and see what happens, either at home. It's a food. It's not poison. You can do it at home. Or, in our office if you're not sure if something happened, what caused it, all those things. So I think that's the generalities that was in the second question, how do you know if you have a food allergy? What would I say if somebody had said they were found to be allergic based on essentially a subjective muscle test, usually when a child or even the parent sometimes is holding a vial with some food allergen or other environmental allergen, and they test to see if the allergen affects your muscle strength. And I would say it's not something that's scientifically based, and it's not necessarily worth your money. That being said, some of the people that do that test also have a treatment which involves avoidance or other versions of, I'd say, a song and a dance, and then reintroduction, which itself, if you are truly allergic, would be a problem. It could be a problem. Question, you probably would win a Nobel Prize. So the question is, why are there more kids with food allergies now than there were 15 years ago, or even 20 years ago, or 30 years ago when most of us were kids? There were food allergies back then. They just were way less common. But what was also present back then was asthma and eczema, and maybe even I had a food allergy. My mom says, my birthday's tomorrow, and she reminds me I had egg allergy, but I don't remember that. Well, so in that sense, there is more allergies in general. There's more asthma. There's more allergic rhinitis, which is runny, stuffy, drippy, sneezy nose. There's more kids with eczema. And there is more kids with food allergies, not just, you hear a lot of stuff about people saying they have an allergy when they don't. There is really more people with allergies. So getting to that, there's good ideas about why that's occurring. I think they're probably right in that if you look at where you're from, we're born in the east side, and there's a lot of parents who are from India, but their kids are born here, and they don't have any allergies, but their kids have a lot of food allergies. My mom had allergies, I have allergies, my son has food allergies and eczema and all that. So in that sense, there is an atopic march within individuals, but there's probably an atopic march within generations, in that the genes have always been around. Why are they being expressed currently? Well, if you looked in East Berlin in the 1980s, there was no food allergies and very little asthma or regular allergies. But in West Berlin, which if nobody remembers geography, was actually in East Germany, but it was westernized and had all the modern amenities that, say, London or New York would have. They had just as many food allergies asthma and allergies as London and New York and Cleveland did. As soon as that wall came down, within 10 years, East Berlin, people had just as many allergies. So there's definitely something about a Western society, or growing up in a Western society, that seems to unmask allergies. Maybe it's the fact that there's no parasitic diseases, or at least very few, pinworm even anymore. I know it's around still, but we don't go to the local watering hole and get a worm in our foot that goes up in our muscles and then comes out of our lungs. That's not fun. So one trade-off is we don't get as many infections. In babies, no E. coli from the unpasteurized milk or less pasteurized milk. We have a lot of hand sanitizers and cleaning agents for our kitchens. We have dishwashers. There's all these things that our kids probably don't get exposed even when they're inside of their mother's uterus. My wife's an OB. She hates the word womb. So inside the mom's uterus, that these exposures are less in America or other westernized countries than they are in other countries. But as those countries change, it will probably change there too, at least within pockets, like big cities in China, big cities in India. That will happen. It is something just generally described as the hygiene hypothesis, and they've seen that in many different countries, even in America. If you look at the Amish population, there's very few, if any, allergies. They don't live in East Berlin, they live right down the road. So there's a lot of those exposures that are around, but we just don't usually have them in Westlake and so on and Cleveland Heights and stuff. So that's the general idea. I hope that wasn't too long-winded. What other questions? Actually throw out a second, more recent cause, which is at least particular to America and maybe England and other countries, is that from 2000 until 2008, and you'll remember this at least, we had told all the kids or parents of new babies, especially if they had eczema or other allergic disease in their family, to wait until 3 years old to give peanuts, or 2 years old to give eggs, or 1 year old to give milk, and that was completely wrong. They had actually rescinded those recommendations in 2008 after they realized that their goal, which was of course to decrease the number of kids with allergies from 2000 to 2008, they saw it was just still going way up. Experiment, terrible, horrible social experiment failed. So they said, let's not do that. It's hard to get messages like, stop doing something we told you to do out. So even still I see pediatricians saying to do that, and it's not true, especially since in 2008 they started that study that came out of England called LEAP, which is called Learning Early About Peanut Allergies, where they finally tried to ask the question in a scientific way. Is giving a kid at a young age peanuts better or is it worse? So they took a bunch of kids who had eczema that was severe, or who already had another food allergy, in this case was egg, and they broke them up into two groups. One group was, if you're not already allergic, meaning if you did the skin test and it was positive but they ate it and nothing happened, you eat peanuts every week until 5 years old. The next other group, just avoid peanuts until 5 years old. The group that ate the peanuts, nobody became allergic, and with their kind of statistical analysis, essentially the kids who were avoiding it had 80% more peanut allergies. So actually it's the other way around. 80% reduction by eating it early. So in that sense, it proved that that recommendation from 2000 to 2008 of avoidance is wrong. And it also proves that, at least for peanut, unnecessary avoidance increases your risk for becoming allergic, especially in kids who have eczema or another food allergy. So we know that for peanut. Do we know it for walnut? We don't know. They haven't done a randomized trial that takes 8 years to do and millions of dollars to study. But in the absence of evidence, okay, you're going to give your kid food early or you're going to just wait. What would you do? For me, it wasn't even much of a question. I'd just say, let's see what happens. Talk to your doctor if you have another food allergy about that, because kids who already have a food allergy are at risk for other food allergies, but it's a matter of doing it safely. So I think at least in general populations, the recommendation is do whatever you want in a safe form, so you're not eating cashews at 11 months old, so they choke on it. But that's just a general concept. Also, I think it's why there's more peanut allergies now, that recommendation. Guilt too. No, there should be no guilt. my wife says to my kids is, we don't blame, right? So actually during those years of avoidance in England, they were yelling at mothers more for eating peanuts while pregnant than they were about drinking alcohol, which is ridiculous. Not that alcohol is terrible, it's not good, of course, but the peanut thing was just overblown in a way. The situation is whatever you eat while pregnant has nothing to do with it. Whatever you eat while breastfeeding through your breast milk has nothing to do with it. The point of that LEAP study was that ingestion of the food decreases allergy. One of the thoughts about why there's more allergies is because of that avoidance strategy was that just because you're not eating the food, just because the baby's not eating peanuts at 10 months old, doesn't mean they're not being exposed. So you guys, I mean, most of you have kids with food allergies. If you eat a peanut butter and jelly sandwich, or if I eat pizza at my house, which I love cheese, and my son has to avoid it, then you just got to wash your hands. Because you know now, if you touch them, they're going to get a hive, because the cheese is on your fingers, as is the peanut. So maybe that's why my son has milk allergy and had it the first time he ever had milk, because I wasn't washing my hands with cheese and yogurt and all those other things we like, but I just didn't think about it. But if you're going to have a baby and you have a kid with food allergy, maybe the recommendation then is eat the food, just wash your hands before you pick up your baby, and then put them in the pigsty so they get the bad bacteria, right? So no, there should be no guilt. We don't blame. It's not necessary nor helpful to go that direction. So right, so let me clarify. If a kid has eczema or broken skin barrier, it might be that the foods that are stuck to your fingers, you lick your finger and wipe it off, it's not really gone. Food is kind of like bacteria. It's sticky, it's everywhere. When you pick up your baby to breastfeed, maybe that peanut protein's on your fingers and it touches their face or their back or their skin, especially when their kids' skin with eczema is already inflamed and broken. The skin barrier from eczema is dysfunctional. That's what eczema is. It's not food allergy, it's a skin barrier dysfunction. Maybe it gets through that way. This is all, again, theoretical. They know that if they smear rats with peanut butter on their tail, if they have eczema, they become peanut allergic. So that's one of the thoughts. You can't do that study in kids, though. So, and nor would you sign up your kid for that study. So, but hey, why not just wash your hands? It's such an easy thing. Don't blame, right? In that sense, it might have happened anyways. It's hard to really know. Obviously, it was, so just to clarify, foods that you eat do get into breast milk, but what that causes is really not fully understood, or at least it's known for the anaphylaxis. It doesn't increase the risk. For me, downtown is the easiest place to get into, though it's still hard. My Solon and Twinsburg clinics are worse, I'll have to say that. And I presume you live over here.
In Elyria, so
Al Melton.
by no means do we want to go to Twinsburg.
It actually might even be easier than going to main campus, I'll tell you. Al Melton is excellent. He trained me essentially, and I've trained him, I think. And he's at Fairview.
Okay.
So that's something as an option. That's one of the problems in food allergy in general, is that there's not a lot of allergists. There are a lot of allergists. There are allergists around, but maybe they didn't train when food allergy was so prevalent, and maybe they don't feel comfortable with some of the very rapid changes that are occurring in food allergy, like the peanut study, which I kind of anticipated, but I was lucky. And those kind of changes need to be made fast, and it's hard to change things when you've been doing them the same for a long time. And it's also hard when you don't have the experience in doing food challenges in your office, because at least until 3 years ago, you made no money. You lost money doing food challenges, but they finally changed the code and the relative value of doing a food challenge, and now you actually can afford as a doctor to do a food challenge. So that's one of the other problems that we dealt with for years. So Chick-fil-A, sorry, I was trying to use brands. Deep fried peanut oil, that's fine. But if they deep fry the shrimp in the peanut oil and you have shrimp allergy, that may not be fine. Milk allergy, we don't know. Probably okay. For many reasons, especially with multiple food allergies. So yeah, it's scary to be able to go to restaurants and feel comfortable that what's going on in the back is safe for your kid. because you never really know. You're not back there cooking it. The question was overall, it is frustrating when there's a lot of medical literature out there and even doctors have trouble sorting it out and knowing what's right for an individual patient. Studies are about populations. The patient in front of you is different, and every patient is different. So that can be very difficult. Actually, I joined a Facebook group recently and saw a lot of problems, both from the message from doctors, even allergists, and of course interpretation. But I saw a lot of frustration about the fact that they try to read non-medical parents try to read all these studies and don't know which ones to pick because there's literally hundreds of studies, but there's probably one or two or three a year that are worth even reading. Okay, so that's the real problem. Being able for me to know which studies are good and bad took a few years of training, and it's really tough if you don't have that perspective. So it can be very difficult and frustrating and overwhelming, and it happens all the time. So I think the comment was, my goal is for my parents, my patients' parents, and my patients I see adults, is to be experts in their own disease and actually probably know more about the ER physician or even their pediatrician by the time they leave their office, or at least have that as a goal through the years, right? So, and if I say it in a way that's too confusing, or if other doctors do it, you should say, I don't understand, and make sure that before you walk out you do have your questions answered. So the avoidance, which is kind of the topic about restaurants, I put down resources for the most part, but I was going to leave it open to asking questions of the audience of, if you have questions about those kind of things. So,
Sorry, Pete.
that's okay. I don't think that foods are the sole cause of autism in the same way that, and probably less, that they contribute to eczema, for example. And that there's so many potential factors that it's hard to pinpoint one. It's always simple to be able to say one thing is the cause when even the disease of eczema or the disease of asthma or the disease of autism, really those words are descriptors of maybe 500 diseases or 5,000 diseases, but they all tend to show up and look the same. So it makes it very tough to say there's one cause or one contributing factor, in the same way that the genes that cause food allergy are like 50 genes, and it's so complex it's very hard to study. It's not like CF where it's one gene. So that's probably the case of autism. There is a risk for avoidance of food, like I said, for peanuts especially, for sure, and likely other, at least plant-based foods like tree nuts, that unnecessary avoidance is a risk. And so I think people need to think about that, especially if there is eczema going on. And then the other risk is there's a whole lot of tests that are available, like the muscle testing or IgG blood testing, which is not IgE. So IgE is the good allergy test, and even that's not a perfect test. IgG testing is available, even the clinic will do it, but it's worthless because of the false positive issue. So then people get into the cycle of let's avoid 1, 2, 3, 4 foods. As you know, that's not the easiest thing to do, and it can cause problems, especially in kids who need nutrition to grow. So for example, with kids with milk allergy, there's really good evidence. They're shorter, they're smaller, and they don't get to be as big for reasons that may not be fully clear. But the nutrition is something to really think about. So the other risk is malnutrition, or at the very least stunting their height or weight just through avoidance, especially if it's milk and eggs and wheat and other things. Wheat especially. I can't talk about the Atkins for sure, and I certainly think that's hard. I would say, look, if you're going to do it with your doctor or your pediatrician to make sure you're doing it in a safe way. If you want to do it just for a little bit and see, there's 2 steps to a test for these intolerances I talked about. Any other non-anaphylactic type reaction. The first test is avoid the food and see it go away. The second part, which most people don't get to, is avoid food, see it go away. The second part is reintroduce food see symptoms come back or get worse again. Because time cures a lot of things. Avoid food, kid gets better. Maybe they were going to get better when you were eating the food. So that's the only way to know. And it's especially hard when they can't verbalize that, right?
Exactly.
So yeah, I mean, it's tough. Like I said, if you want to do it safely. It's just a matter of doing it in a way that's systematic and doesn't get too confusing for correlation equaling causation. So avoid 3 foods, see it get better. Who knows? Maybe they get cranky because they ain't getting their good food. You got to think about that too. The problem is we eat 3 times a day, sometimes more, right? And things happen a lot during the day. It's always going to be hard to tell what happens. Why. So the question is, when you're avoiding a number of foods, for example, how do you make sure you get the nutrients that you need? If you're avoiding 1 food, it's very reasonable to see a dietitian. If you're avoiding 2 foods, you should see a dietitian. That's what I've grown to realize myself and hadn't always been referring patients. So I've been doing it more recently. That's my thoughts about that. I have knowledge about it, but not nearly as much as they do. But it also needs to be a nutritionist who kind of knows what's going on. And will be able to work with you and your kid, personality-wise, because it's not going to be a short-term relationship if it's multiple foods. That would be, I think, the best way to do it. At the very least, if you identify problems, talking to your doctor about it. I would say, in general, the question or comment was that foods that have a lot of long ingredients or chemical ingredients or other things are very hard to think about to give. I'd say I recognize it. In general, at least for immune responses to things, it's actually kind of paradoxical in that chemicals are harder to react to than proteins. So when people are worried about pesticides or chemicals on the actual food, if they had a reaction, it was the food, right? It's the peanut, not the stuff that's on it, causing the allergic reaction at the very least. Whether you're concerned about long-term nutrition or other things like that, not nutrition, long-term side effects that are either known or unknown of those kind of ingredients is a whole other issue. But in terms of allergy, those ingredients never cause reactions. Let me give you an example. In Europe, they've banned red dye number 40. Guess what nobody ever has a reaction to in terms of anaphylaxis? Red dye number 40. Guess what's one of the substitutes for red dye number 40? Carmine dye. It's made from if you think about it, it's kind of weird, an insect from South America, and it is a protein, and people do have, though it's rare, anaphylaxis to carmine dye. So that kind of regulation, which is meant, of course, to help either unknown side effects or perceived side effects of, say, red dye number 40, may actually increase the risk for food allergy and food allergic kids. So that's the hard balance that nobody knows the answer to, what's better. But at least I would try to reassure people about, I'm going to say, a neologism, chemical-y ingredients. For allergy, I don't worry about them very much. But I recognize the concern for other reasons. Right. So in general, I'd say a lot of the kids here have eczema, right? I tell people that poison ivy is natural and it's non-GMO. But you wouldn't put it all over your kid's skin, right? So a lot of natural oils, well, the thing that causes poison ivy is the urushiol, which is the oil that the plant produces. Well, people with eczema, at least, can become sensitized to a lot of the natural oils that are in skincare products like jojoba oil. It's a nut, but it's probably going to cause more eczema reaction than it is anaphylaxis. So in general, my recommendation for eczema kids is to stick with companies like Vanicream, Vanicream company, Cetaphil, CeraVe, the hypoallergenic brands, Aquaphor, these kind of companies that don't use these natural sensitizers and use chemically type of stuff. But for sunscreen, I tell people usually if you're using something and it's not causing problems, keep using it. If it is causing problems, then the zinc oxide, titanium dioxide containing stuff from those companies is good, because my wife bought some from Costco and it had like 50 oils on it, and all food oils. I'm like, not that he's allergic to it, but who knows when you can become allergic to it. So that's what I usually do. If you're worried about anaphylaxis, I wouldn't be too worried about it in general, because if it's going to cause a reaction, it'll cause it where you touch it. And if you're not sure, rub a little bit amount instead of covering them all over first time. So what I mean is, put a little dab on a forearm, wait the next day, see what happens. If nothing happens, use it. If it does cause a rash, okay, put their medicine on and don't use that. Would be a simple, generic way of figuring it out. Did you have a question? Yeah. Hypoallergenic, non-soap cleanser. Yeah. I use White Dove bar soap at home because it's at Costco. It's cheaper. So I like to do the cheapest stuff available. Cetaphil may be cheaper than CeraVe. And to answer anybody's question if they already have it, Cetaphil does have almond oil in it. I've never seen almond oil causing reaction. It's been reported, but I'll say almonds are the least common tree nut allergy. I've seen 3 real cases in 6 years of actual practice, not in training. So yes, I use those kind of hypoallergenic, non-soap cleansers. Talking about soap off of food allergy topic, the natural soap is soap. It still dries the skin out a lot more than gentle cleansing soaps like Dove, Cetaphil, CeraVe, Vanicream, Oil of Olay, Aveeno. There's a number. There's all these options. So. And you had a question? That's another ingredient. Propylene glycol is an ingredient that's in a lot of skincare products that you can have eczema type reactions to, sure. Voting for the right.
A parent asked the question, the EpiPen is so expensive, I can't afford it. What can I do about that?
People in Congress and recognizing that it's a long-term problem, not just with epinephrine, but with a lot of drugs, especially with a lot of the high deductible plans that are going on. If you qualify at the very least, I know there are patient assistance programs from the actual company. This goes for other companies, but if you don't qualify, then you're kind of screwed. They're coming with the generic Mylan, which is coming out with a generic EpiPen. There are other companies coming, but it's not going to be this year or probably next year. The generic EpiPen will help people in your situation. It's basically a scam for other people, to be honest, but it at least will decrease that price. But it's not like it's going to be, $50. It's still going to be $300 for 2 packs. Just so you know, the coupon for Epi was $100 per twin pack. It's now $300, even though it still says $100. But it's still a lot. It's a tough situation. And there probably are ways of talking to people at the company to figure it out.
Okay.
I don't want to say it too loud, but there are probably ways to deal with that. Shopping around at pharmacies for everything can be very helpful. So warehouse pharmacies, big supermarket pharmacies, like I'm not going to say, try not to say names, but there are a lot of places that have very different pricing than local, on the corner farmers. Was there other questions of any topic really? I'm going to go back to the seafood. So the question was, if you have a seafood allergy, especially shrimp or crab, whether it's safe to swim in the water because it's contacting your skin, or probably also because you're going to be a kid and swallow the water too. I would not worry about it at all. And
would you like to go on vacation with us?
it's easy to say, of course, hard to do. Don't let him play with the crabs, but even if he does, for example, pick up a crab, nothing's going to happen. If it pinches him, it'll probably get a hive where it pinches him. I'm a big fisherman, actually. I have bad dust mite allergy. I did medical school in Tampa, and I would fish live shrimp, and they're pretty sticky, always pointy, and it would cause me to have hives in my fingers when I touched it, when it poked me. But that's me because I could eat shrimp. But for him or your kid, it would only cause a hive where he touches it. So that gets to a good point. I'm glad you brought that up. So one of the things on the back, in fact the bottom one on the back, is I agree with that goal. Of course, prevention is the best treatment, right? So that's definitely a goal. It's a matter of how far do you need to go to get to that, and you could probably get to the same goal without necessarily being too worried about it in general, right? So be vigilant, prepare for the worst, and hope for the best by working hard, as you all are doing, to prevent exposure. But for the most part, this is also a culture change that will probably happen in the next few years in allergy, but small amounts probably aren't bad, exposure-wise. Most kids, for an individual allergen, have a threshold dose between 0 dose and, a full meal. Some kids, it is very low. That's usually teenagers, okay, not usually young kids. Or the young kids that become teenagers, yeah, small amounts is what you hear about on Facebook about the worst possible outcome, right? That's rare, and we hear about it on Facebook because it's like a shark bite. It shouldn't happen. It's horrible when it does. And usually there's something that could have been done to prevent it. So yes, you should worry about it to some degree. But most people don't have that low threshold. Okay, they're actually studying a lot of this for labeling, better labeling practices, but how to be safe and, CYA at the same time as understanding that not everybody has to avoid all these different foods at such a small dose. So that's where, if you're not sure if you're allergic, one, doing a food challenge is helpful because if you don't react, then you know they're not allergic. But there is value in seeing how much they eat before a reaction occurs, if a reaction does occur. That's not why I do challenge. But if it does happen, you see how much they ate and realize that this 2 or 3 first doses, nothing happened. And then if something does happen, well, see what happens, recognize it, and then know how they treat it. Antihistamines, epi, steroids, usually just epi or antihistamines, things like that, if you even need the epi. So I forgot about the juice thing, but small amounts you should worry about overall, but really, really, really small amounts, like, if there was the shrimp in the sea, I wouldn't worry about it at all. So that was actually a question from somebody who wasn't able to show up today. So can I read this question and say if it's similar? The question was, from the outside of the audience, question is, what is the best type of soap to wash your hands or clean the food allergy off so that it's safe? There's 2 parts to this question, so I'll answer the first one. Any soap and water is all you really need. In fact, on the back, there's actually a study which a school pointed out to me that baby wipes are really effective at taking off peanut protein from people's fingers, including the oils. So they did a study where they put peanut butter on somebody's hands, used baby wipes, and they checked their hands for the peanut protein and they couldn't find it. So that's a nice trick for schools who may not want to have every kid go to the 15 seconds soap and water. Baby wipes are a quick and easy and usually fairly cheap option. Yes, it'll work. If it works for peanut butter, it'll work for any food allergen. Your question, I think specifically, is if you have peanut butter on your hands and your kid, say, either touches your hand, it's going to cause a hive maybe, and it may not, where you touch them. If they lick your finger after you licked your finger, you probably licked the protein off. But in some kids, that might cause a reaction if it gets into their mouth. So mouth, mucosal exposure, like other areas, can cause problems. Like, it's just a matter of getting into those areas that allow the allergen into their body easier. The skin is a protective barrier. But if you have a kid with eczema and they smeared peanut butter all over their arm, like a lot, or my son with milk, like if you poured milk all over his body and he had eczema going on, that could cause a reaction that's anaphylaxis. But most often it'll just be hives where it touches. Take him to the shower, wash him off, hands wash, whatever you need to do to get it off. And if there is a hive, you use the antihistamine.
We were told.
Oh, before you go, there's a second part to the question, which is a lot of people ask about, does hand sanitizer work to remove an allergen from their hands? And it doesn't. It moves it around, it kills bacteria, but doesn't get the allergen off the hands. So that's the outside the audience's question, second part.
What about Clorox wipes?
The wipes part of it probably does work. The baby wipes tend to be soft and they probably pick things up a little bit better, so it's hard to extrapolate to Clorox wipes, which may be a little more paper-like. Just like when you wash your hands with soap and water for bacteria, it's not the soap that's helping, it's the water. So in terms of the baby wipes, it's not whatever's in the baby wipes, it's the wiping that wipes it off. If you just kind of quickly smear it and there was a bunch of peanut butter there, it may not get it off. So it's just a matter of how well they do it. If it was like a sponge you have in your sink with a little soap on it, and they did that, I would say probably fine. But the Clorox wipes, if used correctly, I would say it's fine. I just can't say for sure.
On your resources.
I realized I forgot to put the best school, the school resources CDC is there, but that's a long document. Within that document, there are some things like that. There are versions of that. I don't know if I could tell you how to get to them right off the top of my head. So the question is there resources to use as a checklist of what you should talk to your school about and teacher about when your child goes to a new class each year? And it sounds like on the Connecting for Kids Pinterest board that there's a number of options to look at checklists. So that would be a resource. FAIR, the cofargroup.com, which is another website that's not as well known, has some things like that. Sorry, it's on there. That one would be cofargroup.org. That's Consortium of Food Allergy Researchers Group. It's mostly driven by Dr. Sitcher at Mount Sinai and other people with his consortium. So, sure. In general, at the very least, I like talking to the teachers specifically about what they're allergic to and what reaction they will have, be it anaphylaxis or, diarrhea or whatever. Give the teacher some specific things for your child and maybe give them an idea of what has happened in the past to write so that, when they're coughing, and there's 20 kids around, okay, that kid presents with cough, and I got to think, it's either his asthma or what did we just do? Was there food around? Is there a possibility? Our ears perk up right when our kids sneeze and cough and they get little hives, but that's not something that everybody else has automatically, especially people who are maybe younger or don't have as much experience with kids have had reactions. Even a teacher who's been around for a long time, if they haven't seen a reaction, it's hard to recognize. So talk about that specifically and go over with the teacher. Don't let them say my nurse is here. Tell the teacher what symptoms to watch out for. So on one of the handouts I have is the Anaphylaxis Action Plan, which comes from FAIR, Food Allergy Research and Education. That's their version of their Anaphylaxis Action Plan, and it goes over which symptoms for which you would use antihistamines and which symptoms for which you should give epinephrine. And what I wrote on my resource sheet, and I generally tell patients, is you should fear not using the epi more than you should fear giving it. With that being said, my analogy is such that I think of a food allergy reaction as kind of like a fire in the body. I know some people here have heard this. So let's say you touch your kid with a peanut and there's a little hive. Okay, that's a small fire right where they touched it. All right, that fire goes out on its own. You just wipe it off. Maybe the hive will go away on its own in 15 minutes. Some kids get a little bit in their mouth and all they get is a little itchiness of their mouth and maybe some sneezing. So it's a small amount, small reaction, small fire. Give them the antihistamines, like Benadryl, diphenhydramine, Zyrtec or Claritin I've been going a lot to. These are the over-the-counter stuff that your doctor should tell you about which one they want and which dose to use. But antihistamines in general, what I tell people about how they treat the reaction, how they treat the fire is, the antihistamines simply turn down the heat. They make you feel better, but they don't put out the fire. Well, I'm sure people have had experiences here where all I had to do was give the diphenhydramine or an antihistamine. Most fires go out on their own, even if they were a little bit severe. But if the fire is big already, like you're having hives all over, you're having coughing and wheezing, you're vomiting already, and having other symptoms, it's a food allergy reaction, those are the most common symptoms. Or if you're having bad asthma symptoms and throat swelling or low blood pressure, all of those symptoms treated by epinephrine real quick, because the epinephrine puts out the fire. It stops the reaction from happening, so it makes you feel better quickly, and it prevents it from getting worse. That's why it's such a great drug to have epinephrine available. It's just a matter of it doesn't work if you don't use it. And too often teachers, parents, ER doctors, nurses, EMS personnel, they don't want to use it. Okay. The epi puts out the reaction, it treats the fire. Some fires are already big. One dose may not be all you need. That's why you want to. So if one dose doesn't put it out, then you can use a second one 5 minutes later, and that's all on the sheet. More often what I see is the fire goes out, they get better, but then maybe 15, 20 minutes later, though this is unusual, then the reaction comes back. Okay, you can do it again. So that's why there's two. All right. The reason it says on there to go to the ER or call 911 is not because you used the epi. It's not any concern about side effects. It's because you had a reaction where you needed to use epi. And they want to make sure you get to a place where if you need a third dose or other drugs, then you're there. But the thing about it is, the way to make sure the best way to prevent having to go to the ER is to use the epi. But at some point, if it's going to get bad, you're going to have to go no matter what you did. So that's the best way to prevent those reactions you hear about on Facebook. 1, 2, there's no long-term harm from having a reaction.
Okay.
And whether Benadryl or epi would prevent it if there was long-term harm is not known. But if we already know that there's no long-term harm, then who cares? So I wouldn't worry about that in general. But it's just a matter of sometimes it takes antihistamines 20 or 30 minutes to kick in, whereas epi works immediately. So that's the way I would think about it. I think she had a question, then we'll go.
The question was, is there any problem with having a child on a stimulant medicine for ADHD and using an EpiPen?
There are very certain medicines like thyroid medicines or beta blockers we have to be concerned. But at some point, it is what it is. And if you need to treat a reaction, the epinephrine is out of the system in 15 to 20 minutes total. It's like it's gone out of your body. So that's why it works so well. It's not like it stays there for 4 hours, and that's why they're better. They're better because it stopped the reaction. If the worst of the worst case scenarios happens and something really bad happens, guess what the first drug they're going to use is? Epinephrine. So there's really no contraindication to using it to treat anaphylaxis. I feel comfortable saying that for sure.
It's good to hear.
Oh, there's no lowest, so I'm sorry.
No, that's okay.
The question is, what's the lowest weight a kid could be to have an EpiPen Junior? And the answer is, it's not ideal, but there is no lowest weight.
Oh, okay.
Most kids who are under 1 don't have severe reactions, but of course somebody here is going to contradict me. And I agree, that happens. So it is better to use it than to not. Okay? Before they're lifeless, for sure.
Okay, that's great.
And the biggest problem with the pens in babies or infants under 1 is that it probably will hit their bone when it goes in their thigh. And the dose is higher, but that's not as much a problem as, hitting the bone with a needle. Is hitting a bone with a needle a problem? Not really. In emergencies in pediatrics, if you can't get an IV, they put it in your leg bone. So that's not a problem besides the pain. It's not fun. And the dose I would be less worried about. If you're getting into a very bad situation, you should use the EpiPen Junior. One trick would be maybe to pinch their muscle up and do it at a side angle so it doesn't go towards their bone, but it still gets into their muscle. Or have a big baby. Not always a solution. Was there other question? Extreme temperatures in Ohio being very cold. So the question is, should you store the epinephrine? I'm going to break it down. Should you store the epinephrine between, I think it's 55 degrees room temperature and 59 to 86. Thank you for clarifying. 59 to 86. There's studies of situations both ways that would suggest it's not terribly a problem. Try not to have it in those situations when you need it, but if it had been cold and now it's warm, it's probably fine. Don't worry about it. They did a study in Florida about that, about high temperatures in epi, and it's probably not a problem. But I'd say any epinephrine is better than no epinephrine in general. Expired epinephrine, don't do if you can get a new one. It is better than nothing. Recommendation is to replace epinephrine pens when the window, which is already a translucent window, not transparent, it becomes discolored. No, I've never seen one that is discolored. So if you find one, bring it to me. I'd be happy to have it. But yeah, don't use it. Probably the problem is sometimes crystallization, but I'm not sure how you would see that. This actually sounds like a good Facebook sourcing question. Can we find pictures of discolored EpiPens? Though the source might be a problem.
We've had some.
Crystallize, right. So, yeah, it's better not to have a 3 or 4-year-old one then. I was actually wondering if you're going to ask me about black walnuts, dropping black walnuts everywhere, or buckeyes in this state, or horse chestnuts, or acorns. Don't eat acorns. Don't throw them at each other, they hurt. If they are able to crack open a black walnut, they're very strong. Okay? You need a vise to open those things, and they taste really good. But if they touch the nut or that junky yellow then black stuff, which is why it's called a black walnut, gets all over you, you're going to have a terrible mess, but it won't cause a reaction. The same for buckeyes and horse chestnuts, which are more common than buckeyes around here, or acorns.
So what about apples?
Sorry. The question then becomes, what causes people when they go picking apples in the fall to have what's usually called oral allergy syndrome, where they bite into a fresh apple off the tree and they have itchiness in their mouth, on their tongue, and maybe in their throat, and in rare cases even having some swelling of the tongue or throat. What usually causes that is nothing to do with a tree nut allergy. It's the spring birch tree pollen allergy that they have, causing their sneezing, itching, runny nose in the spring. But the problem with that is the skin of the apple has similar proteins in the skin, though there is some in the flesh, that when they bite into it, they get that sensation in their mouth, which is similar to what they would have remembered in the spring with the sneezing, itching in the nose from the pollen, but it's happening in the mouth and the throat. It's called pollen food syndrome, otherwise known as oral allergy syndrome, and it's called oral allergy syndrome because it causes symptoms only in the mouth and throat. That being said, there are about 1% of patients who have that, who may have more severe anaphylaxis, but I've only seen one patient who's had a bad reaction to those kind of things. So it can be hard to figure out, but usually I can figure it out if we test for the environmental pollens and allergens. That's what I would do. I wouldn't even test for the apple. I would test for the birch tree. So that's something that goes for apples. If you have it with apples, you might have it with peaches, cherries, plums. These are stoned fruits, and a few other things. Similarly, if you have ragweed allergy, which is this time of year, you have sneezing, itching outside during ragweed season, then when you eat, say, melons, like watermelon, which is fresh this time of year, or cantaloupe, or honeydews, you get the same oral itching from the flesh, because nobody eats the rind, right? In most cases, if you heat the food, like you eat applesauce or apple pie, no problem. But for melons, like nobody eats cooked watermelon, So, and then there are some patients the heating process doesn't help it, but that's most patients that it does. Peeling it will help in most cases, which makes apple picking much less fun, but just as tasty. What I tell people is you tell me if you want to avoid it, if it's mild, if the benefit of eating the apples is higher than the symptoms, eat it. If it bothers you so much that I don't care if I ever eat apples again, decision made. Don't eat apples again. That's how I think about it. Go ahead.
A parent asked if there were any current studies to desensitize children to food allergies.
Benefit versus risk with everything, whether it's eating apples in the fall or doing a type of therapy that has risk for sure, but probably also has a lot of long-term benefit, especially at younger ages, to some degree. And so from my standpoint as a parent, and from your standpoints as parents, you would say, well, I got nothing versus something with risk. That's something that a lot of parents do take into consideration. They do it. The one thing is that right now it's not usually covered by insurance, though it can be. So a lot of people pay out of pocket to travel to do it outside of research studies. And sometimes I worry that people go and the doctors don't necessarily do a rigorous workup for what absolutely has to be desensitized and therefore avoided, meaning are the kids actually allergic, or are they doing a desensitization and then when they pass the desensitization, they take credit for it when they never needed it in the first place. That would be the one thing I worry about outside of research studies. But in general, it's out there, so I won't deny that. It's coming, it's just not now. If you didn't ask that question, somebody else was thinking it for sure. So I appreciate that question. I also appreciate everybody coming out. I know it's a lot of stuff. I hope I made it more clear, but not less, and tell me if I didn't, because then it'll help me prevent me from doing it again. I made this afternoon, so point out any mistakes I made and things that you might want to have added to something like that. It's appreciated. So, and thank you for Connecting for Kids for having me. So.